Hi, I'm Helen Bauer, and this is the Heart of Hospice podcast. The Heart of Hospice podcast is your source for compassionate and informative discussions about hospice and end-of-life care. I'm a certified hospice and palliative care nurse with over 15 years of experience. Whether you're a caregiver, someone with a serious illness, or you simply need to know more about hospice care, this podcast is for you. Join me as we explore all the aspects of hospice, from the details of caregiving to the emotional and spiritual dimensions of end-of-life journeys. For more resources and to connect with me, visit theheartofhospice.com and find us on Facebook, Instagram, and LinkedIn. Keep listening for today's episode.
This is the Whole Care Network. Helping you tell your story one podcast at a time. Content presented in the following podcast is for information purposes only. Views and opinions expressed in this podcast are solely those of the host and guest and may not represent the views and opinions of the Whole Care Network. Always consult with your physician for any medical advice, and always consult with your attorney for any legal advice. And thank you for listening to the Whole Care Network.
This special episode of the Heart of Hospice podcast, in collaboration with Stanford Healthcare, is being sponsored by Kensington Senior Living. Kensington has senior communities in California, Virginia, New York, and Maryland, bringing the highest quality senior care to America's most sought-after locations. Kensington focuses on relationship-based care, built on the foundation of their promise to love and care for your family as they do their own. Visit KensingtonSeniorLiving.com for more information. This episode of The Heart of Hospice is being sponsored by Care Boss, the latest book by Jennifer O'Brien. Care Boss is the book that reminds family caregivers that they are the CEO of their loved one's care. Jennifer has served in healthcare leadership for over 35 years and was also the personal caregiver for her parents and her husband. Care Boss is written to empower caregivers, but it's more than just a book. It's a workbook and organizational tool as well. Check it out at jenniferaobrien.com.
In this third episode of our special series, in partnership with Stanford Healthcare, I'm talking with Dr. Jocelyn Jiao, a palliative care neurologist, and palliative care social worker Mike Polisso, with a focus on neurodegenerative diseases like Parkinson's, Alzheimer's, and dementia. Dr. Jiao is a board-certified neurologist with the Movement Disorder Center at Stanford Healthcare. She's a board-certified palliative care specialist. She's also a clinical assistant professor with a dual appointment. Her clinical and scholarly interest is in the development of neuropalliative care for people and families living with serious neurological illnesses. Social worker Mike Polisso started his career working in pediatric oncology and neuro-oncology before making the transition to adult palliative care at Stanford. He's currently an inpatient social worker that supports patient and caregivers, and he also helps to train other staff in primary palliative care and supports medical fellows in fostering sustainable practices. This is a fantastic interview with these two guests as part of our Stanford series. You're going to hear Dr. Jiao suggest that the best evidence recommends that palliative care should begin upstream, we've talked about this before, when there's a diagnosis of a neurodegenerative disease. She says she realized that she has a very specialized niche as a neurologist and a palliative care physician, and there are a lot of areas in the country where neurologists and palliative care physicians are scarce, and it's hard to get that kind of care. Jocelyn also provided information about Parkinson's symptoms as a guide for understanding what people might expect with the disease trajectory, especially as it progresses towards end stage or late stage. As a social worker, Mike and I talked about his work helping patients and their caregivers prepare for a future with a serious illness, including the advanced care planning conversations they need to have. Mike and Jocelyn both shared how communicating a life-limiting diagnosis affects them personally as clinicians and the existential grief that came to them with that announcement, giving that information to patients and families. They both had some personal stories that they shared about their most challenging situations in their work and personal lives and how they cared for themselves afterwards. So this is a fantastic conversation. It's a little bit more of a narrow focus than we usually have, but it's such a valuable discussion. There's a lot to learn. Jocelyn and Mike, welcome to the Heart of Hospice podcast. It's great to have you here.
Thank you for having us.
Thank you.
Okay, we're going to take a deep dive. You guys said you were okay with a really deep question as a get-to-know-you question. So, Mike, I'm going to start with you.
Great.
All right, here we go. So your question is actually from the Conversation Project, from one of their tools. So it's an advanced care planning question. And it's, when I die, I want to be alone. And this is like on a scale, this is on the far side, 0. And then 5, I want to be with other people. So in that scale of 0 to 5, when I die, I want to be alone or I want to be with other people. How would you answer that?
Mm-hmm. I think I'd put myself at a 4 on that scale. I'd want to be around certain people, I think.
Certain people.
But I definitely don't want to be alone.
But don't get crazy, right? It's not a 5. Don't sell tickets.
Yeah, I'm not totally. Exactly.
I like that. Okay, Jocelyn, how about you? When you die, you want to be alone. That's the 1 or the 0, or a 5, you want to be with other people.
I think I'll be at like a 1 or a 2. I think I'll want to be pretty alone, especially in the last hours, if I could have a choice. But I bump it up because I really would like to say goodbye to everyone.
Yeah.
If I also had a choice.
I like that. Well, so here's what I would ask. Do you think your family would comply with that if you said, I really don't want a whole lot of people here?
I don't know about that. I think that's also their prerogative. I think I've counseled so many families by this point that at the end of the day, I say, you're going to do what you're going to do. So I wish you peace and strength in that journey.
Yeah, some patience.
Yes. So all I can do is say, I'd like some time alone. I'd like to hear the sound of the ocean. I'd like to see the expanse of the natural world and not be pestered. And, hope that they are able to receive that.
I think that's a really good answer. And I hope that listeners really think about that, because it's hard to follow advanced care plan wishes sometimes, especially if it goes against what we like or what we believe or what we prefer for ourselves. So, yeah, I have seen families go against what somebody asked for. Little things like that. It happens.
Little things, big things happens all the time.
Yeah, absolutely. Let's face it, advanced care planning and those decisions and how they're managed towards the end, it's messy.
Yeah.
It is a messy business. Okay, well, we are diving into end-stage neurodegenerative illnesses with a focus on Parkinson's today, because, Jocelyn, that's your specialty. You guys work in palliative care with Stanford Healthcare, and we are so pleased to partner with you guys for this series that we're doing. So deep dive today into Parkinson's. I think I'm going to be learning from both of you today, so it's going to be good. Jocelyn, we're going to start with you. So you are a palliative care specialist. This is your thing. This is your niche. How is palliative care integrated into the care of someone who has an end-stage neuro diagnosis like Parkinson's? How do you integrate palliative care into their care?
Yeah, I think that, there are many, many implementation models of how palliative care can be integrated into comprehensive care for people living with Parkinson's disease or other kinds of neurodegenerative illnesses. I will say that over time, with mounting evidence. People in my field in the neuropalliative space are trying to advocate for earlier integration, earlier implementation, even thinking about introducing palliative care, at least the concept of it, upon diagnosis of something like Parkinson's disease. So that's the end goal, right? That's the pie in the sky, I think, vision that we all have. And there are many, many steps towards that point, and I will say in different institutions, different care settings, it's more feasible to do that, less feasible in others. Um, in my work as a palliative care specialist and a movement specialist at Stanford, I work with the referring neurology clinics, the other neurologists in my institution to say, hey, I'm here to really be there as an extra layer of support for patients, for families, and also for you when you're starting to get questions from patients and families about, so where is this all going? Or how do I cope with what's coming next? Or how do I navigate the the huge task of finding caregiving or thinking about transitioning to facilities or navigating, the changing functional status of my loved one. I try to at least insert myself into the conversation to say, hey, this is a moment in time in which adding another member to your team who can support your patients and your families might extend, what you as a neurologist are trying to do for your patients. So I really do think that, the critical inflection points in which palliative care can make the most impact on a patient's or a family's life are at those big decision points. And that can come, months, but often years before people reach the dying stage too. I will also say that I see many people who are kind of peri-hospice, meaning who are at the point in time that they're starting to enter that subacute dying phase as well. And my hope is just to also provide whatever support I can during that complicated and difficult transition process.
I think the upstream concept is huge. I mean, hospice and palliative care both. We know that having those conversations earlier, having them at diagnosis is super important. At least you're introducing the idea so that when it's brought up again, I think it has less impact. I think it carries less grief for both the patient and the family caregivers if we have those conversations. Do you ever get pushback from patients and families or even other physicians that associate palliative care with end-of-life care, right? It's super confusing for a lot of folks. Do you ever get any pushback or confusion about that?
I definitely feel like every single palliative care initial visit, I'm usually clarifying the role of palliative care and what our clinic can be helpful with. And I have my, spiel that in which I take people through the idea that palliative care is, available for people at any age or any stage of a serious illness. Because often, when I first meet families, they have, done a little bit of research and they've heard a little bit about palliative care and hospice, but it's easy to conflate those two terms. Within providers, I will say that there's also a range of expertise of that nuance of that spectrum between palliative care and hospice and thereafter as well. I'm lucky enough to be at an institution where I feel, that the Stanford Neurology Department has been hugely supportive of recognizing the importance and value of palliative care earlier on before end of life. So I think, thankfully, I'm able to develop, this neuropalliative clinic in fertile ground where a lot of providers already have a sense that palliative care can do more than, transition people to that end of life stage. So thankfully, like I said, a lot of that work has been done for me by, my predecessors and, my mentors in the field.
It's really nice if you live in an area where that kind of palliative care support is available. But the reality is there are not enough practitioners. And I mean, so I practice in Texas. We have a lot of rural resident patients, and they don't have access to things like that. There's no palliative care team to help them. And really, I think we are lousy as an industry at really using palliative care at any stage, any age. What would you say to that?
I would say that I think it's, I agree with the well-recognized need in the palliative care field that we have a workforce problem. And I will say, as a neurologist, we also have a huge workforce problem. The vast majority of people diagnosed with a neurodegenerative disease, whether it's Alzheimer's disease or Parkinson's disease, never see a neurologist. Let alone a movement disorder specialist like me who has specialist training in medication management and advanced therapies in Parkinson's disease. So within neurology, we already have a huge workforce imbalance between supply and demand. So I definitely recognize that I practice in a very, very specific environment, right? In which not only do my patients have access often to neurology specialists, they also have access to palliative care specialists. And within me, a neurology palliative care specialist, that's a unicorn kind of position. And I totally recognize that. And often I find that the way that I try to navigate that for myself is to go into the community, into whatever community is interested in meeting with me, whether that's local, whether that's regional, whether that's in California or not, just to talk about whatever people are interested in hearing about. So that they meet someone who's interested in what's going on in their patients and their families' lives. And hopefully that can, over time, spread the word.
Yeah. Education, community education, so important. So important. Okay, so let's talk about what late stage, end stage Parkinson's looks like. And let's get a little atomic here, right? Because for a lot of our listeners, they may be family caregivers that can anticipate this with their person that they're caring for. What kind of things do you see with folks who are in stage or late stage Parkinson's patients?
So as many of the families that I work with know, the journey for someone living with Parkinson's disease can look very different from person to person. There's an incredible amount of heterogeneity, even within that single diagnosis, that makes it difficult, for researchers, for clinicians to really give pinpoint advice for families, especially when they're earlier on in the diagnosis. So often when I'm giving counseling about what disease progression looks like, what to look for that tells us the disease is moving onwards, moving into its later stages, I often use the well-traveled analogy of a roadmap. Right? When you have a roadmap, you don't know exactly what the distances between the different markers are, but when you run into the landmark, right, that you are in a different place and that something is happening. And that is often, the visual kind of mind map, roadmap that I will use to think about these signs of later disease or even end-stage Parkinson's disease. So generally, one of the first major landmarks is loss of balance for people living with Parkinson's disease, because essentially if you lose your postural stability, you start needing an assistive device, and often it gets so much worse that you need the help of another person to spot you. That often is when people start to have falls. And falls can be a really traumatic experience for patients and often the family members too. So when my patients start losing their balance and start falling more, and our medication strategies are a little bit less effective in preventing that from happening, that's when I start to open up this conversation with families ideally. After those changes in independence and loss of balance or co-occurring with that are often the non-motor symptoms of Parkinson's disease that we don't have a lot of great treatments for. That includes changes to thinking and cognition, which usually manifest with difficulty with organization, multitasking, keeping to a plan, keeping focus on a task, which really impacts your day-to-day life, your ability to take your medications on time, your ability to keep your appointments, continue with the physical therapy exercises that all your doctors are telling you to do. And alongside the cognitive changes, can emerge other, I think, pretty quality of life impacting non-motor symptoms like labile blood pressure leading to more lightheadedness and falls, changes in swallowing. That can be very concerning for your healthcare team because they might predispose you to infections, and sometimes psychosis, behavioral changes, impulsivity. So often these other non-motor symptoms in the later stages of Parkinson's disease start to become the predominant focus for patients and their caregivers because they're really, really hard problems to manage. They really impact everybody's day-to-day life and the ecosystem of the home and the sense of wellness and well-being. And they're not easy to treat. So in these kinds of later stages, a lot of the focus is on managing these other advanced symptoms. And as people do progress with the disease, if they start developing certain clinical indicators like recurrent infections, recurrent hospitalizations, weight loss, loss of appetite, more issues with swallowing, more frequent falls and fractures, just becoming more vulnerable and frail and having less reserve. I often use the metaphor of less water in your tank, so that even a simple stressor like a flu can really knock you out and really make it difficult for people to fully to recover. That's when I start really thinking, okay, time is shortening. It's time to at least explore, what have people heard about hospice? What have people thought about what's important when time is growing shorter? If they have any particular wishes or hopes or worries for the end of life, that's when I think it's important to break open those conversations.
And I think Parkinson's is a much more complicated illness than the general public gives it credit for, because we generally think of the tremors, right? That's sort of the hallmark sign. And tremors, that's just the physical manifestation of what's going on. But when you have the mentation changes, Parkinson's-related dementia, that really complicates the care of that patient. And of course, that's a huge stressor for that caregiver. This conversation is so good, but we're going to take a quick break. Hang on for more great content.
The Heart of Hospice podcast is proud to partner with Stanford Healthcare to bring you this special 4-part series sponsored by Kensington Senior Living. Kensington focuses on relationship-based care built on the foundation of their promise to love and care for your family as they do their own. With communities in Northern and Southern California, Virginia, New York, and Maryland, they're working to provide the most loving and expert care in a comfortable setting, bringing the highest quality senior care to America's most sought-after locations. Caregiver Susan Evans shares how a move to a Kensington facility affected her family.
I was first introduced to Kensington in 2015. Our family made the difficult decision to move my father to Kensington in Northern California. Moving my father to Kensington was the best decision and hardest I have ever made. My father was happier, more content, and definitely less agitated. Kensington Senior Living gave my parents their relationship back and gave me the quality time back with both my mother and father.
Kensington weaves heartfelt professional care into the everyday lives of residents. They offer a wide range of services and amenities so residents can live securely, unburdened, and well attended in a beautiful community they're pleased to call home. For more information, visit kensingtonseniorliving.com. This episode of The Heart of Hospice is being sponsored by CareBoss, the latest book by Jennifer O'Brien. Jennifer O'Brien has served in healthcare leadership for over 35 years and was also the personal caregiver for her parents and her husband, Dr. Bob Limberg. She is the author of The Hospice Doctor's Widow, an art journal of caregiving and grief. CareBoss is her latest book, and it's more than just a book. It's a workbook and organizer that enables family caregivers to lead their loved ones' care sensitively and effectively. Jennifer writes with compassion and hard-earned wisdom, and readers will appreciate the empowerment and camaraderie they find in the pages of CareBoss. CareBoss reminds family caregivers that they are the CEO of their loved one's care. You can find CareBoss at your local indie bookstore or on Amazon and on Jennifer's personal website at jenniferaobrien.com.
So, Mike, let's talk about some of this because these folks, a lot of them have several years of journeying through this diagnosis. It's a long journey for most caregivers that are having to manage the care of a loved one with a neurodegenerative disorder like Parkinson's or Alzheimer's or dementia. So, as a social worker, how do you provide care for these patients and their families as part of the palliative care team?
It's complicated and it's hard and it's individual for every family. But while I was listening to Jocelyn talk about all the loss that happens, I really find myself focusing on supporting families through that loss and caregivers who are watching that and trying to adjust as best they can to all the various losses that Jocelyn was talking about. And you're right, those things can happen over the course of many years. And so this idea of grief and loss is really prolonged over that entire course. And I think it starts, in this kind of upstream model, it starts on diagnosis. People, I imagine, and have experience with, supporting families who just receive a diagnosis and they're grieving immediately. They've lost what they've thought about their future. They've lost plans. They've lost kind of a fantasy about what they wanted the future to look like. And they're kind of hit with this reality that they might not have it in the same way that they were envisioning it. And so I think about the opportunity for support for patients and for caregivers and additional family members that maybe even aren't providing direct physical care, but are emotional supports for our patients and families and caregivers. I think about supporting them through that loss at the beginning and thinking really kind of keeping this mindset of kind of planning for the end as somebody who can guide families through this process at the start, keeping the ending in mind from the get.
When I hear you say this, and I've been listening to what Jocelyn has been saying about the upstream introduction of palliative care, at diagnosis, start having those conversations. It sounds like having those conversations all along, even if they're not really in depth, but just introducing the topic, that would lessen the stress for a caregiver than if there's a catastrophic event like a fall with a fracture that results in a hospitalization and maybe pneumonia, things like that go along with a complication like that. If it's less stressful for a caregiver, if those conversations about palliative care and hospice have already been introduced, so there's a gradual, instead of here's an acute event and we're going to lay this out on you right now. One of the things we say here on the podcast is an ambulance is a terrible place to do advanced care planning. Right? Yeah. Those decisions in a crisis, they're so much harder. What would you add to that?
I think there's just a lot of worry from providers, from caregivers, from patients when they hear about a serious illness diagnosis, Parkinson's included, and other neurodegenerative diseases, I imagine. There's just a lot of worry that we're going to cause additional stress and anxiety by talking about the fact that patients are, on the grand roadmap. There's one ending to this roadmap. And talking about dying feels like it might actually increase anxiety or increase worry for everyone. And I think, in the moment, it might be a distressing conversation. But to your point, I think the more that we can talk about it and support people through that conversation, the more empowered they are to participate actually in that process, and to it gives them opportunity to take advantage of choices that they might have, and those decision points, on the roadmap that Jocelyn is talking about. It hopefully empowers them to support their caregiver, or to support the patient, to support folks around the patient in a way that empowers them to participate and make decisions for themselves. But I think the worry is valid, because it is a hard conversation, and it can
for
be
sure.
a distressing thing. It's important to consider as providers, when we're feeling that worry that we might make things harder or worse by bringing up something we know to be true. It's important for us to check in with ourselves about that too, and acknowledge that worry and understand what that worry is doing to us, if it's making us avoid conversations or not. Maybe it's a kind of, that worry is a sign for us that we do need to talk about it. And so it kind of clues us in that we have more conversations to have with our patients and with their families and caregivers. And so I think the worry is actually a really important piece of this.
I think that's completely legitimate. Jocelyn, what were you going to add?
I was going to say, thinking about the worry that providers have, it really resonates with my own personal experience. I remember when I first was training in movement disorders as a subspecialty. I was doing my fellowship in movement disorders, and before that point in time, I had primarily worked as a neurology resident in the hospital, taking care of the sickest people who have a neurological condition. And then I moved to the outpatient setting, where I was meeting people in clinic, right? Meeting patients and families as they're coming in on their way to work, or, after dropping off their grandkids, and seeing them in their day-to-day life. And I remember, suddenly being the person in the room making a diagnosis of a life-limiting and chronic neurological disease that's not only going to lead to a shortened lifespan, but going to fundamentally change the way that people live and relate to the people most important to them. And I remember being in that position, learning and feeling completely overwhelmed by the existential grief that I was feeling in the room, and not knowing really how to process or metabolize it. I was so anxious about making these diagnoses. I remember I would just lie awake at night wondering, should I have gotten more testing? Should I have done this? Should I have done that? Because what you say changes people's lives in the way that they think of the people dearest to them. And that was so difficult, I think, as a person, as a provider, to gain comfort and traction with. It was completely unexpected too. No one told me ahead of time that I would be experiencing all of this countertransference, or whatever you call it. All that
That's
kind
what it's
of
called.
Grief. Yes. Okay, good. Thank you. My psychiatrist colleagues.
Most people who are working in healthcare that work with people who are seriously ill or have a life-limiting illness, we're fairly empathic. And we always worry about causing people to lose hope. So if we have this persona where, we've got the professional thing going, and we keep the poker face, right? We keep the game face on when we're talking to our patients. It's always safe to assume that we walk out that door and we feel that loss with these people. We feel their loss, even if it's just an anticipated loss. None of this is easy, whether you're receiving it or whether you're the one delivering it. And I think it's important to validate that.
Yeah. I will cite just one study that I have found very helpful for me, especially because it targets the patient population that I care for the most, which is people living with Parkinson's disease. This is a study by Kieran Tuck, I think from the late 2010s, in which a survey was sent out to people living with Parkinson's disease in Oregon. And they were just asked, when would you want to talk with your neurologist about A, B, C, D? And people got to vote about their preference to talk about advanced care planning, about end-of-life options, about hospice, about disease progression. And I will say there was a spread. Some people really did share their preference was to wait to talk about all of those things until after the disease had progressed or until very late. Although the thing that I think was really, surprising and reframing for me as a movement disorder specialist was to see some people wanted to talk about advanced care planning, end-of-life options upon diagnosis, or another option was during the first few visits with your neurologist. And I think when you totaled up the numbers, it was a significant portion of people. So 30 to 40% of people actually opted to talk about those things with their neurologist upon diagnosis or within the first few visits. And I realized in my own practice that I had been waiting too. And that made me feel more emboldened to understand some people are going to want to talk about things sooner. And the only way I will know is if I ask.
Yes.
So in my own practice now, I will say, even as a, dual trained palliative specialist, I don't always bring up, what is most important to you as time is growing shorter when I'm first meeting people, but I will ask what kinds of medical information are important or helpful for you about what the future holds. So I will kind of open up that conversation, even when I'm first meeting people, to say, hey, this is just me getting to know you, to know your information, sharing and receiving preferences, help, let's reflect a little bit. Like, what kinds of medical information are you interested in knowing? What style, what pace? And then I can kind of detail my counseling based on, what they're sharing about themselves. And I can kind of meet them where they are. And that also allows people to kind of voice the preference. If they are the kind of people who want to plan like 5 years, 10 years down the line, we can start doing that now.
Mike, you had something you wanted to add.
Yeah.
I love that approach of asking preferences. And I'm just thinking about also like the role of curiosity and normalizing when we're asking preferences, kind of acknowledging as providers that this might be the first time somebody's been asked that question. And so their instinct reaction and instinct answer, we can explore that too. And we can be curious about why they have that answer. Or, hey, if they're like, I don't want to know any details about that, I think we can validate and accept that and explore it at the same time. And I just want to empower our providers to get comfortable asking curious questions about answers to some of those preference questions so that we really do understand or have a better understanding as best we can about why our patients are preferring what they prefer. I think sometimes it can be like a total lack of knowledge, or I'm really open to like lots of answers to why people have preferences the way that they do, including a lack of knowledge or family history, or actually a really in-depth knowledge of what's happening, and so they don't want to talk about any of those details. But also I'm thinking it from the social work perspective of like what is their coping with detailed information about their health? Have they ever had to do something like that? Have they ever had to cope with that kind of information before? Is it just so scary in the face of getting this new diagnosis to say, yes, I want to know more? And can we put supports in place to make it less scary so that we can talk to them about what's important to them? And so I think about just being curious and exploring that. And I love, like, that is such a great opportunity for the interdisciplinary team in palliative care to really engage with those patients, to help understand what's informing some of those preferences. so that we can take really great care of our patients and even further tailor our plan and communication to their needs.
That's a fantastic idea, because I think a lot of times if somebody says, I don't want any information, I don't want to know details, I don't have any questions, I think a lot of times we shut it down as, well, they're just in denial. They're just in denial. But there's a whole lot of reasons people can't have conversations like that. Maybe it's a cultural thing, depending on who they are, what their lives have been like, how they've lived. Maybe they're just overwhelmed by information and they can't go that far right now. That's a lot to lay on somebody. Yeah. So, Mike, what do you find is the biggest misconception about the role of a social worker in palliative care? Because a lot of times social workers are seen as from the government.
Totally.
You've heard it. So what misconceptions have you found?
Yeah, I think social work as a profession has a lot of work to do in this area, because social workers are found in the government, for example, and they're part of many different groups and part of many different systems. And so I don't blame anybody, providers, families, anyone else, for having kind of different understandings of what social work does. I'm sure that there are social workers that are doing work that I don't even understand as somebody in the field.
Sure.
And so there's just so many different roles, and it's so broad that it's never surprising to me for me to hear that families don't know exactly what social work can do. And I think, we were talking before about kind of areas that don't have as robust of teams and services, especially as Stanford does, or in Palo Alto, or, I think that there's places in America where social workers are utilized, to support their patients in the best way that they possibly can. And that might look really different than what we do in Palo Alto at Stanford.
Yeah.
And so I just recognize that even a palliative care social worker can have a totally different role than me here in Stanford. So I think misconception, I think we do some of it to ourselves. And then I think there's also misconceptions about the difference between palliative care social work and hospice social work, and some of the ways that I like to differentiate for patients that are asking lots of questions to help them understand the difference between palliative and hospice is, especially around social work, is I think about palliative care social work being available much earlier in somebody's serious illness journey, and they can support in a variety of ways because they're involved early. We can support with medical decision making, complex medical decision making, family dynamics that are impacting care, and we might be the first people to actually point out that might be happening, because it might just be normal for families to be kind of engaged in a way like they're just doing their thing. They're just being a family. Their relationships are what they are. And then we see them, we have a little bit of a different lens, and we see how those systems interact with our system in healthcare. And we can help systems navigate our very complicated system. Whereas when I think about hospice social work, I think about patients being in a much different stage of their illness. And I think about grief and bereavement work and anticipatory guidance that's really important for folks.
Yes.
Nearing the end of their life. And so that's kind of how I differentiate the two clinical roles between palliative and hospice social work.
Yeah, quite a bit more counseling when it comes to hospice social work. Yes.
Yeah,
okay,
especially in that grief and bereavement space.
Absolutely. And such a vital part of the care that hospice provides. Absolutely.
Yeah.
Okay, so we're going to dig a little deep now. Tell me about a time, Jocelyn, we'll start with you, when you experienced compassion fatigue and how you provided for your self-care.
Okay, I'll tell you probably about one of the hardest experiences I've had in my life in my medical training, because I think it was a very formative experience, just as a forewarning. When I was a neurology resident, working in the neurocritical care unit, where people are being bridged through, if possible, an acute and neurologically devastating condition. So these are the very large life-ending strokes. These are the intracerebral, so the brain bleeds from various reasons. These are the sickest people that neurologists really take care of. I was taking care of, I think, a young-ish gentleman who was essentially brain dead, though so sick that we couldn't even finish our procedures that can declare brain death. He was so sick that he wouldn't even survive those procedures. And I was trying to discuss with his wife what was going on and trying to frame, the totality and the irreversible nature of his brain damage and brain death. And I remember in that moment going on a limb, trying to think holistically or empathically and asking her how their children were doing. And she said she had told them that he was just sick and in the hospital, and she hadn't told them that he was dying. And I told her in that moment, as a trainee without a lot of experience, it sounds like they might want to say goodbye because he's dying. And I wonder if your children would want that opportunity to say goodbye. And I remember she had a 14-year-old daughter who came into the ICU room, and I was in the room. There were, I think, like 20 other family members in there. It was so crowded. It was full of people praying out loud. And the 14-year-old, she threw herself on her father's body, sobbing, and begged me to save his life and begged me to transfer him to another hospital.
Oh, wow.
Asked me, in her acute grief, if there was anything else that could be done. And just, was having an acute grief reaction in the room. And I had never witnessed that nor supported anyone through that. And I remember feeling so physically ill. I got through the rest of the day, and then I remember probably a couple hours later, I felt so ill. I didn't know what was going on. I had to run out of the ICU. I took the elevators down to the basement where my call room was, and I thought I was going to vomit because I felt nauseous and I felt horrible, and I thought I'm coming down with an infection or something. And I got into the room and I started crying hysterically for around an hour, and then I went back up and finished my shift. And I remember after that feeling so conflicted because not only was it really difficult to witness because I was experiencing that kind of grief, but I was also really angry. I was angry at the patient's family. I was angry at the patient. I felt helpless and disappointed in myself that I wasn't able to provide some sort of magical healing experience, some sort of goodbye that I feel like on popular television seems to just happen when you get the right ingredients in the room.
Touched by an angel kind of thing. Mm-hmm.
Right. And I was angry at my failure to communicate, that what I considered to be the physiologic truth of the nature. And I was angry at myself, I think more than anything, for what I perceived to be traumatizing, a young woman who was losing her father. And that was a wound that for many years just couldn't heal over. I was so angry at myself. I felt like I'd really failed in a way that I didn't realize that I could fail. So that was really impactful for me. And I think one of the ways in which I have eventually over time is, I promise this is not an advertisement to do hospice and palliative medicine fellowship, but I do think one of the most healing experiences was to do a hospice and palliative medicine fellowship and to become a palliative care specialist and to gain some sort of skill set, to respond to or at least hold space for really, really difficult moments, to feel less helpless in that kind of situation. And also to gradually over time learn to forgive my own past self for the person that I was at that time, as well-meaning or well-intended as I was. I was still very much in training, and didn't have the skills or the knowledge to really provide, I think, empathic care in that situation. So that's really one of my origin stories, one of the driving forces for why my career has looked the way that it has looked. I needed to heal and I needed to forgive myself over time.
Yeah, that was redemption for you. I love it. Thank you for sharing something so personal. Mike, how about you? Tell me about a time when you experienced an event that caused you some compassion fatigue and how you provided for your own self-care.
Jocelyn was talking about a professional experience. Is it okay if I talk about a personal one as a caregiver?
Absolutely, yes. I would love that.
So my mom had ALS. She had ALS for 8 years, and as a family, we took care of her together. And she had, just to give a little context, she had an idea of what palliative care was, did not want it. She had an idea of what hospice was and what it meant, did not want it. And so
were you working in palliative care at the time?
No, this was before my career. No, this was
okay,
before
because I would say,
my
Mom,
career in palliative care.
You need to get with it.
I tried. She's stubborn. Yeah. And so I'm thinking about, I'm just to set a little context for, I'm the oldest boy. I'm the oldest of 5, and so the caregiving really fell onto my dad and my older sister and I. And I can remember having lots of compassion and just a well of compassion for my mom at the time, who we were watching lose many of her physical abilities, independence, and who was dealing with her grief in her own way while we were all doing it around her as well in our own ways. And I remember she couldn't talk anymore, and we were using this board that we would point at letters and she'd spell words to us. And I remember just not being able to get it right, and that being the most overwhelming emotional experience of my time taking care of her. And I don't think we were, when I look back on it, I'm like, I don't think we were having a serious conversation. I don't think she was asking me to do anything. It was like me and my mom just trying to communicate and not being able to get it right in that moment. And I remember having to take a ton of space for myself. I remember being like, why am I so overwhelmed by not getting something so simple and what seemed, fun, could have been a fun conversation. It was just a random conversation that we were having, but it impacted me in a way that I couldn't stay in the room with her. I had to go get somebody else to be with her for a time. I had to leave. I had to get outside. I had to experience that overwhelming feeling and that overwhelming emotion and just let it pass through me, I think, in a way that helped me identify whoa, I need a break. I need to take some space here. That was a frustrating thing, but it's impacting me like it was a totally devastating thing. Yeah. And so I kind of recognized this really large reaction to something that was simple as like, oh, my tank is empty. My compassion tank is empty. I'm frustrated that my mom's not doing it right. She's not using her eyes. And when I say this now, I'm like, oh my God, we were using her eyes to communicate. And like I can get back into that place of like, of course this was hard for both of us, but it really just exploded. This really simple moment exploded, and that was a huge sign for me that like I needed some space. And I felt a lot of guilt about having to take space and ask somebody else to come and relieve me of my caregiving responsibilities from shift. And I think taking space allowed me time to process that. It allowed me time to like even feel the guilt and kind of acknowledge in myself that exists, and that it's okay that exists. And I think it highlighted too that all the losses that our patients are experiencing at the time, and all the various reactions that are happening for family members. We hear about them in clinic, and I hear about them as a social worker. Caregivers like really judging themselves for not doing it right, for not being perfect, for not having the right words, or for throwing the communication board, whatever it is. I hear that judgment. I feel that judgment. I feel like I understand that judgment as a caregiver as well.
Yeah, that's a really valuable perspective. And I'm so glad that you shared that story, because I think a lot of times we forget that these professional caregivers, because we are in a care profession, a lot of us are also family caregivers, unpaid family caregivers in our personal lives. Doesn't actually make us any better at it. We still get impatient. We still grieve. We still get frustrated. We still have the questions. We still push back. We have a caregiving experience that's really just the same as everybody else's. We may know a few more things, or know some resources, or some clinical trajectories. But when it comes to the care of your person, that stuff kind of flies out the door, right? Yeah. We're just people, just like everybody else. You guys are awesome. Thank you so much for being on the show. Your insight is amazing, and I'm so glad to have both of you.
Thanks so much, Ellen.
Thank you for having us.
Thanks for listening to the Heart of Hospice podcast. Check out our sponsor in the show notes, and please leave a rating and review on Apple Podcasts. We would appreciate it if you would share this episode with your friends and family, and anyone who needs to know more about hospice. Connect with us on Facebook, Instagram, and LinkedIn. And remember, no matter who you are or where you are in your hospice journey, you are the heart of hospice.
This is the Whole Care Network. Helping you tell your story one podcast at a time.